Right. We may have gotten a little bit further than this in lecture, but I backed up just a little bit so we can talk through this case study and then spend some time on the stages because you will need to know the stages for your test. So in our case study, we have this 26-year-old man comes via paramedics to the ED with multiple gunshot wounds. He's unresponsive. You can see his blood pressure is really low, heart rate is high. So what type of shock are we experiencing here? Hopefully you said hypovolemic. What other clinical manifestations might you see then in this patient who's hypovolemic? So as this patient continues to progress here, so we're starting to take care of him. His heart rate continues to increase. It's now 188. His blood pressure is now 50/32, and he has no urine output since admission. His bowel sounds are hypoactive and his skin is cool and clammy. So what stage of shock is this patient in? Hopefully you said compensatory. And what compensation mechanisms are working to maintain his cardiac output? So that one's a little trickier. We're going to answer that here. So in the initial stages of shock, it's usually not clinically apparent. Our metabolism is just changing at that cellular level from aerobic to anaerobic. So that process requires oxygen that's unavailable due to our decreased tissue perfusion. So our lactic acid is building up and needs to be removed by the liver, but our liver is potentially not being perfused like it should, hence this downward spiral. So in our compensatory stages, we've talked quite a bit about this. We can have different kinds of mechanisms. We can have neural, hormonal, biochemical, all these different ways that the body's trying to make up for what's going on and trying to make sure to get the oxygen where it needs to go, where it's most important. So it's the attempt to overcome the consequences of the anaerobic metabolism and then to maintain homeostasis. So in our compensatory stage, we have the SNS response to our decreased blood pressure. So we're going to see the vasoconstriction while we maintain blood flow to the vital organs, so mostly our heart and our brain. Our drop in blood pressure is really going to be a classic sign due to our decreased cardiac output and pulse pressure that we're seeing here. We're going to have an increase in rate and depth of respirations. We're also going to see dead space in the lungs. So when the patient does take a deep breath, all of that air is not going to be able to take part in our gas exchange, therefore even causing more of a downward spiral. So we're going to see our impaired GI motility. We're going to see our cool, clammy skin. Decreased blood to the kidneys is going to activate that renin-angiotensin system. So we know that angiotensin is a potent vasoconstrictor. So that's going to help increase blood flow to the heart. In this stage, our body is still compensating okay. So if we can find the cause and reverse it, our patients can still recover here. There's no real permanent damage yet. So progressive stage, this is when our compensatory mechanisms start to fail. We're going to see our decreased cellular perfusion and altered capillary permeability. So as that capillary permeability is altered, we have more and more fluid and protein in the vascular space, which is just further complicating everything. We're going to see a lot of changes in mental status at this stage. So that's going to be one of the big ones we're going to focus on for the progressive stage. Our cardiac output is decreasing even more, resulting in even more decreased blood pressure. But we're really going to focus on those mental status changes here for the progressive stage. Pay close attention to table 42.5 in your book for all the different types of shock and all the different stages and what you will see in those. So as the mucosal barrier of the GI system becomes ischemic, we're going to see the ulcers, GI bleeding, decreased ability to absorb our nutrients. our hypoperfusion is going to lead to renal tube ischemia, and then our liver is failing to metabolize the drugs and the waste. So that's why we see the buildup of the lactic acid. That's a big reason why we see the mental status changes, is because of the buildup of these waste products. All right, and then the refractory stage. So basically everything we've started to experience in progressive is just getting worse. We're going to have increased capillary permeability, increased edema, just increased everything. We're going to see an exacerbation of the anaerobic metabolism, even more accumulation of that lactic acid and waste products, even more profound hypotension, hypoxemia. Our tachycardia is going to worsen, and then failure of one organ system starts to affect all the others. So as far as diagnostic studies, obviously getting a thorough history and physical exam, because we need to figure out the cause. If we can't figure out the cause and reverse it, we're just playing catch up, constantly trying to fix whatever new issue has come about. So we really need to find the cause. So there's really not one single diagnostic study that we're going to focus on for this, because it's really going to depend on the history and the physical exam. We might do blood studies, we might do an EKG, chest x-ray. We're going to obviously be monitoring pulse ox, just all kinds of that hemodynamic monitoring. So our friend here, he got 3 units of blood, EKG, chest x-ray. He's going to the OR so they can get the bullets out and repair his injuries. So at this stage of shock, what other things are necessary? What other interventions would be focused on for him? We're going to talk through it. So general overall things, some of this is just super basic. We're obviously going to make sure the patient's responsive, make sure their airway is patent, and maximize that oxygen delivery. So much of what we've been talking about is focused on the fact that we cannot get the oxygen where we need it to go. So maximum oxygen delivery is going to be key. We want to increase our supply. We want to use fluid replacement or drugs, transfusion potentially to increase our hemoglobin levels. We want to try to increase our arterial oxygen supply with supplemental oxygen. We might be putting these patients on a ventilator to try to increase that oxygen supply, and then just avoiding any kind of cares that are going to disrupt the O2 supply, because our demand is so high that if we can get these patients, the more oxygen we can get these patients, the better, in particular, because this is the big issue. The big issue is our decreased O2 and blood flow to our vital organs. All right. So as we think about our therapy for septic, hypovolemic, and anaphylactic shock, we've talked a lot about volume expansion. For cardiogenic shock, that's a little different. We want to be a little bit more careful, but fluid responsiveness is determined by all kinds of different things. Our vital signs, particularly our blood pressure, is going to be key to tell us if our cardiac output is improved. But ultimately, our urine output is a really good indicator for us to know if blood flow has been restored to the kidneys. So while blood pressure is going to tell us what's going on with the heart, it's not telling us. So remember, the body's going to send what it needs to the heart first before it sends what it needs to the kidneys. So the blood pressure may improve, but yet we still don't have enough blood to go to the kidneys. So the kidneys are still not being perfused. Therefore, our urine output is still low. Then we would want to assume that we still need more volume expansion. We're going to look at our perfusion pressures. We're going to see a cap refill. That's going to tell us, one of the last things to return is probably going to be a good cap refill. Neurostatus, skin temperature, and then that urine output is going to be one of our really key indicators that we're going to watch for. It's something that's really measurable for us. We know what normal is. We know what it was before. We can really see if it's improving. Some of the others are a little harder. Is the neurostatus improving? Well, how confused were they? Exactly what they could they remember? If these patients are sedated or on a ventilator or something, we can't even really assess that. So the urine output is just really a measurable way for us to tell if our volume expansion is working. So 2 major complications that we're going to experience when we're using large volumes of fluids for these patients are hypothermia and coagulopathy. So if the fluids are cold, obviously that is going to make hypothermia an issue. So we need to think about if we're just giving a patient one bag of fluids, then not the end of the world. But if we're pushing bag after bag after bag of cold fluids, then we need to think about potentially warming those. And then coagulopathy. So when we are giving fluids, whether it be packed red blood cells or just saline or whatever, there are no clotting factors. So I think sometimes we forget that when we're giving PRBCs that there's no clotting factors. And so if we gave, 4 or 5 units of PRBCs that didn't have clotting factors, so now it's all mixed together, and obviously we have a mismatch in, we have a low, well, just a potential for bleeding, obviously. When we see persistent hypotension after adequate fluid administration, then we really need to focus on potential vasopressors, but typically we try fluids first. So when we're thinking about the drugs, like I just said, vasopressors are typically used only after we try fluid replacement. The reason for that is because they can cause an increase in our systemic vascular resistance and therefore increase the workload of the heart. So particularly harming a patient in cardiogenic shock, but really we don't want to increase the workload of the heart when there's already so much going on as it is. Another key thing to remember is that our vasopressors won't work without adequate fluid volume. So once again, all the more reason to make sure we try fluids first and then we go the route of the vasopressors. We're going to use our vasodilators to potentially decrease our afterload. We're going to monitor our hemodynamic parameters and obviously really good assessments here. Just a little visual again. I'm not going to go through all this, but just kind of what's going on, what kinds of things we would see to show us that that's the issue, and then where we might go as far as interventions. Okay, so real quick, we'll think about nutrition therapy. So this is really vital to decreasing our morbidity from shock. So we're going to start thinking about enteral nutrition within the first 24 hours. That's going to look like just a slow drip of a small amount of enteral nutrition. Really for here, we're not necessarily trying our first focus. As we get a little bit further on, we really want them to get nutrition. Our very first focus at the beginning with just a small amount is just to keep their stomach perfused. So we need to prevent the complications that are going to happen if there's no perfusion. So that's kind of what we're focused on first. And then as we get a little bit further in and as we're able to figure out the cause and kind of get the patient more stable, then we definitely need them to have the nutrition to be able to heal. But first, we're just focused on keeping the stomach perfused, preventing those complications that come from that. We're only going to do the parental nutrition if enteral nutrition is contraindicated, because once again, when we're doing the parental, we're not helping perfuse the stomach at all. So then we're going to have to worry about all those complications that come when the stomach is not being used. So keep in mind, there is a difference. Enteral versus parental. If you see that on a test, just think through which one is it talking about, which one do we want to use. We're always going to use enteral if we can. So that is the most important thing to remember. Enteral is better because it's going to actually help the stomach to do its job, work, and help us perfuse. We are going to be weighing our patient. That's going to help us see if what we're doing is working. Interprofessional care. Same thing we've been talking about, restoring blood flow, So this is focused on the cardiogenic shock. So restoring blood flow to the myocardium by restoring that balance between the O2 supply and demand. So sometimes you're going to use angioplasty, you're going to have stenting to help that blood flow, emergency revascularization, and valve replacement. We talked about some of that with our MI patients. We're going to have drug therapy, so we're going to use nitrates to dilate our coronary arteries. We're going to use diuretics to reduce our preload, vasodilators to reduce afterload, and then those B-adrenergic blockers to reduce our heart rate. You will hear the term circulatory assist devices. I don't think that I have any questions on the test about this. These are kind of real specific. Just really knowing what they are is probably enough, but these are some options or different types. And then a heart transplant is obviously another option in the real severe cases. All right, interpersonal care for the hypovolemic shock. You're going to focus on stopping the fluid loss and then restoring the volume. So as we think about calculating our fluid resuscitation, we use a 3-to-1 rule, 3 mils of an isotonic crystalloid for every 1 mil of estimated blood loss. So I don't think you will need to calculate that for a test, but just know know that it's a 3-to-1 rule and know that we're focused on our isotonic crystalloids. So in our case study, his surgery is successful. They get rid of the bullets, they repair the blood vessels. Estimated blood loss is 3 liters and 1 lure. During surgery, what fluids would we give to stabilize his volume? So remember, our crystalloids don't cause a major fluid shift. So our crystalloids are going to be our normal saline, our LR, or our D5, because we want to keep the fluids in the vascular space. So as we think about what fluids to give, we're going to think about probably normal saline or LR, potentially D5, and then we're going to use that 3-to-1 ratio. He's intubated. He has a central line catheter and an ART line. You can see his vitals here as we think about what medications he will receive. We'll talk about that here, and we kind of already did, but obviously fluid replacement is the first thing. We want to restore that intravascular volume. We want to perfuse the organs. So we'll start 30 mils per kilogram of an isotonic crystalloid solution. Then we're going to think about those vasopressors, so some epi or another type. And then we're going to think about IV corticosteroids for patients who really still cannot maintain an adequate blood pressure with the vasopressor therapy and the fluid resuscitation. We're also going to think about antibiotics. So we want to start those within the first hour for a patient that's in shock. So that is a huge, huge, huge thing in the ED is getting those cultures drawn and then the antibiotics started. So we do always want to make sure the cultures are drawn before we start the antibiotic. We don't need any kind of result from the culture. Those take a long time to come back. We just want them drawn before we start the antibiotic, and that is important to know. We want to keep our glucose below 180 if possible to help prevent more infection and stress on the body. Proton pump inhibitors for those stress ulcers, and then VTE prophylaxis as well. As far as neurogenic shock, we have to focus on our spinal stability, really treating that hypotension and bradycardia with our vasopressors, potentially atropine. We're going to increase our fluids a little bit more cautiously than maybe we would with like a hypovolemic shock, but not nearly as much so as the cardiogenic shock. And then we're going to keep an eye on our hypothermia as well, not just because of the cold fluids that we might be infusing, but because of the different areas of the brain and how they regulate our body temperature, and potentially injury to those areas can cause problems. We'll talk more about that last part in our neuro lecture. So then for anaphylactic shock, epi is obviously our drug of choice, but we're also going to do Benadryl, potentially like a famotidine or something along those lines. We're going to maintain our patent airway, so whether we need to intubate before the swelling gets too high, we're going to have aggressive fluid resuscitation, and then we're going to have potential using IV corticosteroids if we have significant hypotension after an hour or two after we've already done aggressive therapy. Okay, and then obstructive shock. So our primary strategy is just the early recognition and treatment to relieve that obstruction. So however we need to do that, depending on what kind of obstruction we're talking about, where it is. So we can do some kind of mechanical decompression, some kind of thrombolytic therapy, radiation, debulking, removal of a mass, decompressive laparotomy. Just really, I mean, we talked about all the different kinds, so it truly just depends on what kind we're talking about here. Okay, our case study, airway and breathing are successfully managed via ventilator. His incisions dry and intact. Blood pressure and heart rate are fairly normal here. So what other assessment measures are necessary at this point? So he's not dying at this moment. We fixed a lot of his issues, a lot of the important things. So now what are we going to focus on? So we did our ABCs, tissue perfusion, and we kind of go down the list of most important to least important. So we're going to obviously be keeping an eye on our vital signs, peripheral pulses, level of consciousness, cap refill, skin, urine output, all that stuff that we've been talking about. His mother and his girlfriend arrive in the ICU. His mother tells you he has a history of GERD, but otherwise he's pretty healthy. So as we think about care goals, we're just really focused on that adequate tissue perfusion. We're focused on restoring normal or baseline blood pressure, recovery of our organ function, avoiding complications due to a prolonged hypoperfusion, and then preventing healthcare-associated complications. So a lot of these things that we've talked about as far as interventions have their own complications. So we put in a catheter. Okay, what's the complication of that? Now we have potential, infection issues. Same with our central lines and our art lines and all that kind of stuff. Even just making sure that we are following isolation precautions for all of our patients so that we're not sharing. We have the risk of hospital-acquired pneumonia for patients that are not able to move around a whole lot. So many things that end up being complications because of our interventions, unfortunately. So our patient stabilizes over the next couple days. He's extubated, recognizes family, has lots of questions about why he's here. So then nursing implications. As far as neurostatus, we want to keep an eye on their orientation and level of consciousness every 1 to 2 hours. So we're going to orient to person, place, time, events, cardiovascular status. We're going to monitor their heart rate. We're going to have them on continuous EKG. A lot of times they're going to have the continuous CVP, all these different things that we're watching for as far as their heart. We're checking for dysrhythmias, we're listening for murmurs, making sure that there's no further complications. As far as respiratory rise, this is all pretty standard, so I'm just kind of going through this real quick here, but all of our normal stuff, including checking blood gases occasionally. Renal status, we're mostly focused on our urine output, but we are going to monitor our serum creatinine to see how we're doing there. We're going to take core temperatures. We're going to watch for our skin issues, including temperature, but also some of the other things to tell us how well we're perfusing our skin. We're going to be listening for bowel sounds. We're going to be keeping an eye on an NG tube and any drainage it might have, making sure we don't see blood there, and checking our stools for blood as well. And then just that personal hygiene and emotional support is key as well. So when we think about emotional support, we want to think about anxiety and fear that they're going to have about this potentially happening again, or what caused this. And then we're going to talk about their pain as well. So, but most importantly, giving them privacy, making sure their call light's within reach, explaining everything, doing our drugs as needed. Some of these patients with the hypovolemic shock, you're going to see on for search when we're there, you're going to see patients with gunshot wounds. And those patients, you really got to think about like what kind of environment are they then discharging into. So I tell a story of when I was a fairly new nurse, I had a patient who was in with a gunshot wound, and had surgery, everything was fixed, and he needed to go home on Lovenox. And so I taught him all about the Lovenox and how he needed to monitor for bleeding because this med was going to make him bleed. And how, he really needed to make sure he was being careful, with his razor, just making sure he didn't get cuts. And if he did, he needs to be holding pressure on them because they're going to bleed way more than normal, all this stuff that I'm telling him. And as he's getting ready to leave, I hear him talking to his mom on the phone and he says, Mom, I'm going to come stay with you for a little bit because I'm going home on this blood thinner and I just got to make sure I ain't be getting stabbed and shot and stuff right now while I'm on this blood thinner. So I'm going to come over for a while. So it was just like it was this normal thing for this guy that he just like might get stabbed. So it's just things we don't think about. Just crazy. All right, you can see these questions here. I'm not going to go through all of these with you, but you can see the answers. So go through these on your own if you'd like. Try to think if there's any that I really want to point anything out, but we've pretty much talked about all of this before. So this one, if we've progressed beyond the compensatory stage, what might we see if you think about the glucose, sodium, calcium, or potassium? Increased serum potassium. So why would that be? Potentially because other organs are not being perfused that help us regulate our potassium. Septic shock. What are we going to see here as far as our heart? We're going to see our decreased systemic vascular resistance. Okay, so that's the end of this portion, and then there is a separate file for your SIRS and MODS lecture, so make sure you listen to that one as well.